Thank you for the kind introduction. Can you hear me on the back? Great. I was trying to explain to my husband what I would talk about, and it took me 10 minutes, so I decided to change the title of my talk. And basically, I will talk about the effects of overlapping neurodegenerative diseases. These are my disclosures. And I would like to start showing this very interesting case. One of my roles back in San Francisco is to participate in the autopsy program. And a while ago, we had the brain of this gentleman. He was 86 when he passed away. He was a retired journalist, no family history of dementia, and he was seen in our clinics around the age 80. And he had a very interesting clinical phenotype. He first expressed some depression, very profound apathy, and myoexecutive dysfunction. It progressed. About 3 years after the beginning of the symptoms, he started to have mild short memory impairment, but it was not so bad. Mostly what he got worsening was the executive dysfunction. At a certain point, he started to have bipolar-like behavior. He became more obsessed, inhibited, aggressive, and finally he passed away about 10 years after the onset. When I went to medical school, every Monday we had clinical pathological conferences. And this was a situation that we had unexplained medical symptoms. We would get there and get completely blank. We could not remember anything. But one thing I could remember very well until today is that if you wouldn't discuss first the syndromic diagnosis, followed by the anatomical and followed by the etiological, the open peer review will be very unfavorable to us. So this is something I remember, and actually this is pretty much what we do in our clinics. When a patient steps in with Alzheimer's disease, for instance, we use a combination of clinical history, neurological exam, and neuropsychiatry testing to come up with a syndromic diagnosis, for instance, Alzheimer's dementia. And in this case of this gentleman, he fit criteria for behavioral variant FTD. He had early apathy, dietary changes, and also his neuropsychological profile with executive and generation deficits, with spare memory was really fit the criteria for behavioral variant FTD. So how about the anatomical diagnosis? Even before the advent of imaging, we could pretty much do a good anatomical diagnosis thanks to this highly specialization of the brain. Of course, this is just a cartoon, but each area of the brain has a different function. So based on the clinical symptoms, we can predict which areas of the brain are degenerating more or first. And finally, we have to come to the etiological diagnosis. And in case of neurodegenerative disease, our question is, what is the molecular signature of the disease? That basically is what we will probably use to treat the disease in the future. And, well, we don't have very good biomarkers for this in vivo, but because each neurodegenerative disease targets a unique neural network, as it was well exemplified, for instance, in the case of Alzheimer's disease, showing that the neurofibrillary changes in the cortex after it affects the subcortical structures first involve the hippocampus and entorhinal cortex, and from there it spreads to other limbic areas and association cortex. And finally, it involves pretty much all the cortex, but it still spares some primary areas as the premotor area. You see it's quite clear here, or the primary hearing area. And based on this, plus the predicted anatomical changes of the disease, we can guess at least what would be the disease underlying the clinical symptoms. And this was also well exemplified by recent imaging findings. This is resting state MRI. This work was made by my colleague Bill Seeley at UCSF, and he could show that each clinical phenotype that we see in neurodegenerative disease, like Alzheimer's disease, behavioral variant FTD, semantic dementia, and so on, hits a preferential network in the brain. So how about our case here? So this was a patient with behavioral variant FTD. For those who are familiar with these symptoms, we know that the underlying condition can be anything, but in most of the cases what we have is disease with protein TDP43. But in this specific case, this gentleman, he had pure Alzheimer's disease. You can see here the angular gyrus is stained for amyloid, full of plaques. And the same area is stained for phospho-tau, full of tangles and threads. So it was a typical case of Alzheimer's disease. So how can you explain a clinical case of behavioral variant FTD with underlying pure Alzheimer's disease? Well, actually, in this case, it was not so pure. What we found in some areas, especially the areas of the brain responsible for behavior, like anterior cingulate and anterior insula, we found in the white matter here. Usually in Alzheimer's disease, the white matter is sparrow. Magnification, we detected that these changes are active changes. So would you explain the disease? About it, but these changes result in changes described by David Munoz back in 2007 in cases that had a clear aphasia, but the pathology was Alzheimer's disease, the white matter of the Broca area. So changes ATEC, argyrophilic thorny astrocyte. This is not a defined neurodegenerative entity, modifier of So in summary, we saw FTD underlined by Alzheimer's disease by a localized maybe was the cause of the different. So we can think, okay, so a mixture of different neurodegenerative a typical phenotype, and then suspect of the diagnosis. It can be. Before we continue, I would like to show this. So from Gabor Kovacs, who is my colleague in this conference. They look at population-based clinical pathological studies less than 15, and they pull together the results to predict which percentage were found in this population-based. So, for instance, in most they found Alzheimer's disease, but also the so someone who had different fit criteria, I mean it was severe enough to fit criteria of more than 15 to up to over 40%. So let's move now. This is also a retired journalist in our clinic, age of 77, and he had sister had a history of Alzheimer's disease, and his case was so typical. He fit the clinical trial for a drug against beta amyloid. This is his MRI, also showing here atrophic, and there is atrophy also in the frontal. As expected for Alzheimer's disease, but for our surprise, encephalopathy, which is this disease that had repetitive brain traumatic disorders, famous because of American football players, and this is. He had a lot of tau deposition, especially the surface of the cortex. It was more pronounced at the tip of the sulcus, and it has this predominant. CTE is not a disease with pure hippocampal sclerosis. He also has diffuse axonal of the disease and TDP changes. So basically, neuropathy, but it was really typical Alzheimer's disease. And so how to explain it? So we'll keep it for a little bit further on. First, I presented a case with a typical presentation disease that had a modifier. Then I presented neuropathies in the brain, but the clinical phenotype. And now I would like to present a case of another patient. This was a woman. She came over 60. The onset was the age of 58, much. And at the beginning, she had loss of the even a check anymore, and she also had progressive. Started to have speech impairment, and she didn't have a history of dementia. This disease progressed for 14 years. Diagnosis of cortical basal syndrome. So these are the pretty much got this diagnosis because the problem, it was a Parkinson's plus syndrome. It was not what she had. Actually was a plus Parkinson's disease. Usually, especially early on in the condition, but in her case, that the clinical manifestation on the area of the brain that is affected by inter-individual signature itself, syndrome anatomic, but they are not necessarily predictors of the underlying disease. Multiple neurodegenerative conditions is the individuals. This is not exception, and may not cause a typical clinical gender. Overcome this problem and tackle this question. Certainly, we need precise biomarkers for understanding in vivo. There are several candidates, markers, very, very few approved, but there is a lot of research on. Promising one are PET scans with. There are some tracers. Clinical trial, it's not perfect, but several traces for tau being tested, right? F markers. We are talking about diagnosis disease that it really has an implication. To give a word of caution, a courtesy of Professor Voitala. When we think about biomarkers for neurodegenerative, the fact that no common disease have positives. So in a disease that 1,000, like Parkinson's disease, for instance, false positives in the sample is much higher than a disease. So let me try to explain. Imagine this is a population of 1,000, like Parkinson's disease, and much higher than. We'll have one individual here who will have the disease. If we get a test, a biomarker that has a 0.9%, in this one false positive. So it means that when we sample 1,000 positive and 1 false positive. So imagine if of the population of our clinical trial will be a very high implication for the results of, considering that we might have even more than one neurodegenerative condition, even more important. Is the specificity of CSF markers even reach 85%, so this problem might be even presented, and certainly we'll have to use in the of biomarkers to be able to detect this disease. Finish, I think, give if the concept of disease have any influence in the clinical practice. I think we way to make sure what is the underlying mechanism, and certainly we still need more and better biomarkers. I think we are going to this direction. And since we are talking about mixed pathology, I have mixed pathology in the sense that they diseases, but we also see a lot of modifiers shown on the first case. And if you would like to know pathological modifiers in dementia, that's something relatively new, please come to the session on Saturday on Update on Dementia. We'll talk about it. And I would like to finish thanking all my colleagues and co-workers that really collaborate with this research and results. First, I would like to and from the UCSF, the Memory and Agency, including Professor Amaro. He was started these studies 5 years ago. Actually, it was 10 years. And also, of course, to the funding agencies. Without them,
Dr. Greenberg, she's so kind. 5 minutes more. So if are there any discuss?
Thank you very much, Leah, for this excellent presentation. I think as clinician, it leaves us a little. So, of course, we have been for generations been trained to localize in the brain where the lesion responsible for the problem arises. We have to know what is the underlying pathological process. Different, and as you showed, heterogeneity, and also most patients perhaps. What should we do in terms to help our patients?
I think in terms of, well, there is research. I think in research certainly can do clinical trials with these biomarkers. Many of them are not necessarily of the clinical practice. I think at this point any treatment available, but once it becomes in making diagnosis, thinking that will necessarily solve all the problems of that mixed neurodegenerative disease. Sometimes we feel only getting one, and that's it. No.
case was very interesting. And did that, and then in a wider sense, is getting a strong history of trauma?
Thank you for your question. The CT patient indeed, actually, this is not our only case of phenotype of Alzheimer's disease that come up with right now. In this case, he didn't have a clear history. He was a war journalist and he covered several his hearing because of shellings. So maybe this very mild have caused something. Certainly, it's an area that it's open.
Thank you very much.
Thank